We'll come to the conclusion of our mom. She was crying for help. Her baby is febrile. She will take him to Prof. Zamil and Prof. Abdurrahman, well, to the neonatologist. He's only 2 weeks, high fever. Where you will take him? Moms, to the neonatologist or to the infectious disease consultant? Huh? No. Take him to Nawaf Al Dajani because he has both. He is a neonatologist certified with a good training in University of British Columbia, as well as infectious disease fellowship. He is an associate professor of pediatric at King Abdulaziz University and senior consultant neonatologist now because his white beard started to appear. You have 20 minutes.
يعني جات علي أنا شلحني تخلي حرمتك تتكلم ساعتين. طيب I will make it very summarized إن شاء الله. I grew in this holy city. Alhamdulillah, I spent like 7 years here. بعدين المدينة تنفي خبثها فمشيت أنا من المدينة. Okay. طيب, nothing to disclose. We have seen the first generation, Dr. Al-Nimri. And you, Dr. Professor. I am second generation. Today I see the third generation. Dr. Abdul Salam is my ex-trainee and now he's surpassing us. صار أحسن منا. I will skip a lot of slides, huh? Because he is threatening me the. Okay. I'll just skip all of those ones. So everybody knows how the fever physiology is. Fever is always due to infection, could be an inflammatory. Everybody knows that macrophages get activated by external bioregions, and then some inflammatory marker like interleukin 6 and 1 tumor necrosis factor through prostaglandin E to elevate the set point. So not every fever is due to infection. Don't get the neonatal or the infant with tympanic or skin. Always use rectal or axillary, please. Huh? Okay. So what are the changes that we are encountering in this day and age? Change in the bacteriology, new biomarkers are coming up. There are advanced technology, more multi-center collaborative group that make us more confused about the approach. We'll show you. Cost-driven decision. This is also things are getting cost-effective way rather than safety. Okay, the bacteriology, unfortunately the gram-positive are coming less as the gram-positive cocci are coming less like GBS, and E. coli is becoming more common cause of the neonatal and infant infection. And this carry a lot of cost because now most of our gram-negative are becoming more multi-drug resistant like ASBL, and this lead to more exposure to broad spectrum antibiotics. So E. coli is surpassing everyone now. We have more automated system to detect the organism earlier, more multiplex, as Dr. Abdul Salam mentioned, the PCR in the CSF helping us to identify more viral illness rather than bacterial, and then to justify stopping the antibiotics. Biomarker, the best biomarker is the fastest, cheapest, more sensitive, more specific, better negative predictive value, positive predictive value does not exist. So we have the interleukin 6, for example, more used in Europe, very fast. You can get the result 2 hours, but it can go up in 2 hours, but the turnout time is very long. So it takes time until you get the result. Most people, they move to procalcitonin. How many people they use Procal now among the group? So even in the United States, not available in every hospital. We use CRB. A group from United States, New York groups, they make a very smart study when they double or they use 2 cytokines together. Like, for example, the best to use is the CRB in conjunction with interleukin 6, and they have the best predictive value ever, according to the ROC curve. Then the cost, substantial bias among the doctors. Every fever necessitates admission, full septic screen, and so on and so forth. Unnecessary admission, financial cost, potential for healthcare associated infection. So the collaborative group, this is during a NIMRI training, Boston criteria, Philadelphia criteria, Rochester criteria. You remember this? So this is during the 80s to the 90s. They are good, but they are not homogeneous. They are different on term of age, term of epidemiological or risk factor, different in the using CBC cutoff, less than 20, less than 15, less than more than 5,000. And these are really confusing. Now, you cannot really judge the patient sickness based on the WBC. Anybody has faith of normal blood count means reassuring? Anybody who has faith of reassuring CBC, I don't talk to him. There is no reassuring CBC. So you can have meningitis, subdural emphysema, sepsis, pyelonephritis, and the CBC is normal. So the positive predictive value for this is 24%. So it's very poor predictor. And then they found those criteria. The best was the Philadelphia criteria, good, very negative predictive value. Specificity is 19%, a lot of confusion between them. And then there are babies who were assessed as low risk, and then they found to be having serious bacterial infection. So the new group, febrile young infant research, more collaborative group, Intermountain Health Group, Pediatric Emergency Care Applied Research Network, and Pediatric Research Office. There are 4 groups. So what are the problems with this outcome? So every group, we have many problems here. They divide the neonatal period to 3 groups. Less than 8 days doesn't count. They go for full septic screen. And then they divide between 8 days to 22 days, and then from 22 days to 28 days. How confusing is this? Very confusing. Very confusing. Now, because they said we found the infection rate or invasive bacterial infection is less in the 22 days and 28 days compared to the 8 days to 22 days. But they look at only one center. So they get Berkan Center as the standard for the new guidelines. But when you look at the other centers, they actually have high invasive bacterial infection. And then when make it combined also, the infection around 3%. But they get only 0.7%, and this is making a bias of the judgment. Now, confusion is when they come, 8 days to 21 days, everybody gets full septic screen, okay? Admission and antibiotics. Okay. Now here, they use the biomarker as the cutoff when you do lumbar puncture or not to do lumbar puncture, okay? And then here, abnormal inflammatory marker like abnormal procalcitonin, you do lumbar puncture, okay? طيب, no, you may do lumbar puncture. How? Do you know how the neonatologist and the pediatrician are confused already? This is more confusion. You don't need to tell the pediatrician, you know, you may need to do it. It's without talk they will do it. So you make a more classification and more confusion. So what is the benefit of segregating the 28 days to 28 days? Nothing. It's just to make more publication, I think. You know how the neonatologist and pediatrician like to make more. Don't tell me the time is 5 minutes, or I will take until the adhan, inshallah. Because this is a best talk. Let's see what the American hospital following the American guidelines or not, okay? This is John Hopkins, up to 28 days. So no segregation of the 22 to 28. خلاص full septic screen. خلاص؟ ليش نحط نص ونص كنا في المندية ربع ونص معه. This is becoming too ridiculous. طيب, Philadelphia is more sophisticated. They put criteria, inclusion criteria. And then actually, they were more stringent than the American Academy guidelines. If the inflammatory marker, like procalcitonin, is negative, then no lumbar puncture. So, more solid. طيب, Ohio, typical American Academy of Pediatric guidelines. I'll just skip this. You know, here is the European, clear cut. There is nothing called 28 days, 22 days, first 1 week, second week. You get cooked very well, استويت بسرعة ولا لا؟ ما في. So, less than 28 days, straightforward. You see but the problem with the guidelines is no unwell feature. بس يا خلاص اكتب well. ليش no unwell feature? Why you do this? هذا ممكن أقولها أنا because I'm not an English guy. But if you are an English and you write no unwell feature, and it doesn't make sense. And then the problem is with all guidelines is based on the clinical judgment. And this clinical judgment cannot be generalized. You look at him well, you look at him very sick, you look at him, maybe he's iffy. كيف؟ You know, he's a little bit iffy. So يعني نص ونص كده الأمريكان يقولوا صح. All right. So the clinical judgment cannot be يعني تحصل واحد سكوينت ويقول لك والله كويس يا دكتور هو عنده سكوينت. So
5 minutes Nawaf.
خلاص طيب. The prediction model as based all on clinical, well or unwell, or not unwell. خلاص. So, and these are subjective to many doctors. Many of the pediatricians and the neonatologists, you know, they are kind of chicken, you know. Everybody is sick, you know. They cannot send the patient home who has fever, you know. And then they use one single center and they generalize it all over the other centers. Because that center has 0.7% And they ignore the other center. They have 3.2% of invasive bacterial infection. So you cannot bias and make people more confused about your bias. You cannot take this. You have to take the whole combined group. And then if the invasive bacterial infection is 3%, who's going to tolerate this kind of risk? A neonate with 3% invasive bacterial infection. You cannot tolerate even 1%, I guess. Okay? Inflammatory marker, they have been taken off as the cutoff when you do lumbar puncture or not, but they are telling you, you may do a lumbar puncture. So they make you more confused. They are overlapping group between the 22 days to 28 days, the NICE guidelines versus American versus John Hopkins, Philadelphia. Every group, they are using different cutoff. And then phrasing. If you don't look at the guidelines before, they change SIB for IBI. What is this? ها؟ هذه طبعا من علامات المنافقين. إيه يلبسون الحق بالباطل. واضحة. So the American Academy of Pediatrics, they used before serious bacterial infection. قولوا هذه مصيبة. لا, we have to change it to invasive bacterial infection. لأنه لو تعرف عندي serious bacterial infection with 3%, you cannot send me home. خلاص خلوها إيش؟ more, less invasive. نقول يلا invasive bacterial infection. طيب. What is the problem with this approach doing limited study for واحد جاب jaundice ولا fever and you do septic screen? There is a major problem we have. High rate of UTI or high rate of positive urine culture. How many times you see somebody who was admitted for jaundice or fever and then the urine culture came as positive? And this is one of the problems. Now, most of them that are ASBL, should we give meropenem? How long should we treat? And then we take a lot of struggle around. So the guidelines are variable. Clinical judgment is the cornerstone. Treat the patient, don't treat the guidelines. Okay? Debate is the essence of the knowledge, but the truth knowledge we know nothing. خلاص? Every patient should be treated individually. Remember, you are not a Europe or United States. How long it takes for the United States for the ambulance to come to arrive at home? Average. Yeah, 3 to 5 minutes. And in Canada, maybe 3 to 5 minutes. You are not Europe. So if you have an example, somebody coming من الفقرة ولا من خيبر ولا, you cannot go home. Hey, don't send home. يقول لك والله ما عنده العافية نروح نكويه عند السواطية بدل هذا. If somebody who's the parent are well educated, they live in the campus of the university, those kind of patients you may observe. So every patient is totally different. This is how I get after 30 years of medicine, I get more confused. So the confusion is lifelong, okay? Would you send 25 days old according to this criteria home? Fever? Probably not. Hey, هذه من علامات الإيمان. Thank you very much.
First time you finish in time. First time you finish on time. Thank you. ما شاء الله عليك. شكرا جزيلا.